to learn about some of the important ascending tracts. The learning objectives of this class would be to appreciate the arrangement of neurons in ascending pathways, list the sensation carried in dorsal column pathway and anterolateral system, draw labeled schematic diagram to trace the pathway for dorsal column and anterolateral system, understand the physiology of important ascending pathways, define various abnormalities of sensation and give their common causes. The ascending pathways carry sensation from the peripheral structures to the different areas in the brain, mainly via thalamus to the sensory cortex. These pathways are simply set of neurons arranged in series. Usually they have three sets of neurons: first order, the second order, and the third order neurons. These neurons are arranged sequentially in the central nervous system. Some of the pathways have also the higher order of neurons, that is fourth order neurons, for further processing of information in the other part of the cerebral cortex. First order neurons are primary afferent neurons. They start from the receptor and travel in the peripheral nerves to reach the spinal cord via dorsal root. These cell bodies are located in the dorsal root ganglion. After entering the spinal cord, they terminate on the second order neurons in the spinal cord laminae itself, or ascend up in the dorsal column to terminate on the second order neurons in the medulla. Second order neurons, they are either located in the spinal cord or in the brainstem. The primary function of these neurons is to transmit impulse from the first order neurons to the thalamus. As a general rule, second order neurons typically cross the midline, either in the spinal cord or in the medulla. Thus, these neurons transmit the impulses originating in one side of the body to the opposite side of the thalamus. Third order neurons originate from the specific nuclei in the thalamus and terminate in the specific areas in the sensory cortex. Sensations transmitted from different parts of the body are relayed in the thalamus before being projected to the cortex. Therefore, thalamus is considered as the main sensory relay center. Fourth order neurons are usually not included in the sensory pathways. However, sometimes a higher order of neuron originates from the terminals of third order neurons in the sensory cortex and project to the other areas of brain, especially to the cortical sensory association area, for further processing of the sensory information. Classification of these tracts. Ascending pathways are typically divided into three categories: the dorsal column pathways, anterolateral system, and the ascending pathways, other ascending pathways. Dorsal column pathways. Fibers ascending in the dorsal column of the spinal cord are included in this pathway. So this is also called as lemniscal system, as fibers occupy medial lemniscus in the brainstem. Dorsal column pathway transmit following sensation, that is fine touch, vibration, proprioception, tactile localization, tactile discrimination, and stereognosis. Anterolateral system further divided into two parts: the anterior spinothalamic tract and lateral spinothalamic tract. Anterior spinothalamic tract carries sensation of crude touch, and the lateral spinothalamic tract carries sensation of pain and temperature. The other ascending pathways include spinocerebellar tract, which includes dorsal as well as ventral, spinoreticulothalamic tract, spinocervicothalamic tract. Coming to the dorsal column pathways, the large myelinated afferent fibers that enter the dorsal column of the spinal cord to reach the medulla constitute these dorsal column pathways. They carry sensation of fine touch, vibration, proprioception, tactile localization, tactile discrimination, and stereognosis. In the spinal cord, they ascend up in two fasciculi, the gracile fasciculus and cuneate fasciculus. These ascending tracts in the spinal cord are also called as tract of Gall and Burdak. First order neurons arriving from the lower extremity and lower part of the trunk ascend up in the gracile fasciculus, whereas neurons arising from the upper extremity and upper part of the trunk ascend in the cuneate fasciculus. The gracile fasciculus is located medially in the spinal cord and carries sensation from the hind limb and the trunk. The cuneate fasciculus is situated laterally that transmit impulses from upper limb and upper part of the trunk. The first order neurons terminate in the nucleus gracilis and nucleus cuneatus in medulla. Second order neurons, these are going to arise, they are present in the nucleus gracilis and cuneatus in the medulla, and these two nuclei are known as dorsal column nuclei. These fibers originating from these nuclei, the fibers which are originating from these nuclei cross the midline and pass on to the opposite side of the medulla and ascend up to the medial lemniscus to reach the thalamus. The second order neurons thus transmit impulses to the contralateral thalamus. The dorsal column nuclei. There is a somatotropic organization in the dorsal column nuclei with face placed laterally and trunk and hind limb medially. Recently, two cell types have been described in dorsal column nuclei. Accordingly, the dorsal column nuclei are divided into two different zones, cluster and non-cluster zones. The cluster zone is the main part of the dorsal column nuclei in which cells are arranged in clusters. The region receives direct input from the fibers in the dorsal column pathways. Second order of neurons from this region cross over to the opposite side to the east thalamus, and the region informs the thalamus and cortex about the sensory stimulation. Non-cluster region is present more rostrally in the dorsal column nuclei. This region receives input from descending fibers from the cortex and from fibers in the dorsal column pathways. The projection from this region is mainly to the non-thalamic areas like cerebellum, tectum, pretectum, inferior olive, red nucleus, and areas that are involved in motor control. Thus, main function of this region is to provide direct sensory input to the different motor areas of the brain to bring about the immediate regulation of movement by appropriate sensory feedback. The third order neuron originates from the specific nucleus, that is VPL nucleus in the thalamus. The neurons project to the somatosensory areas of cerebral cortex. So this is the schematic diagram showing the dorsal column tract. The first order neuron arises from the receptors. They come to the dorsal root ganglion. They are going to come to the spinal cord, relay in the spinal lamina. Then they are going to form the dorsal column pathway, and they're going to reach to the nucleus gracilis, which is situated medially, and nucleus cuneated, which is situated laterally. Then from there, second order neuron arises and they are going to cross over at the level of medulla. So then they ascend as a medial lemniscus and they go to the specific part of the thalamus. From there, the third order neurons arises. They're going to go to the specific area of the sensory cortex. Coming to anterolateral system, phylogenetically this is older than dorsal column system. It is divided into anterior spinothalamic tract that carries sensation of crude touch and lateral spinothalamic tract that carries sensation of pain and temperature. The first order neurons are primarily afferents originating from the nociceptors, thermoreceptors and mechanoreceptors. The fibers enter the spinal cord through dorsal root and the cell bodies are present in the dorsal root ganglia. In the spinal cord, the fibers terminate on the second order neurons that are present on the same side of the dorsal horn of the spinal cord. The cell bodies of the second order neurons are located mainly in the lamina 1, 2 and 5th in the dorsal horn. The second order neurons present in the dorsal horn of the spinal cord. The axons cross the midline in the same spinal segment and ascend up in the opposite side of the anterolateral funiculus to reach the thalamus. The fibers carrying the sensation of crude touch are placed anteriorly, therefore they are called as anterior or ventral spinothalamic tract. The fibers carrying sensation of pain and temperature are placed laterally and therefore called as lateral spinothalamic tract. The third order neurons originate from the VPL, midline, and intralaminar nuclei of thalamus and project to the specific areas of sensory cortex. So this is the diagram showing the diagram of the anterolateral spinothalamic tract. These are the first order neurons. They go to the dorsal root ganglion. From there, they're going to relay in the lamina of the spinal cord. From there, the second order neuron arises. They are going to cross at the segmental levels, and then they're going to ascend in the opposite spinal cord as a spinal lemniscus, uh, and they're going to reach to the thalamus, and from there third order neurons, they go to the specific part of the sensory cortex. Pathways for specific sensation, like touch. For the touch receptors, touch can be elicited from the skin areas containing no specialized receptors. Thus, it is observed that the free nerve endings mediate touch sensation. However, it has been known that mucinous corpuscle and Pacinian corpuscles are rapidly adapting touch receptors, whereas Merkel's disc and Ruffini's endings are slowly adapting touch receptors. The sodium channel BNC1 is closely linked with touch receptors. This ion channel belongs to the group of proteins called as degenerins that, if hyperexpressed, cause degeneration of the neurons. The receptors are activated by mechanical pressure. These touch receptors are abundantly present in the hands, especially in the fingertips, the lips, and are less in number in proximal part of the limbs and trunk of the body. The receptors are very less in the back and back of the trunk. Usually the receptors are present in more number around the hair follicles. Therefore, movement of hair is a potent stimulus to elicit the touch sensation. They are also present in the skin and subcutaneous tissues of the hairless areas. The pathway for these sensation is, these touch sensation are A beta fibers. Fibers ascend in two pathways, the dorsal column pathway for the fine touch and anterior spinothalamic tract for the crude touch. The touch sensation carried in the dorsal column is well localized and have a better discriminative aspects, whereas the touch sensation carried in the anterolateral system is poorly localized and has a less discriminative aspects. Proprioception and kinesthesia. Proprioception is defined as afferent input arising from the stimulation of the muscle, joint, and muscle, tendon, and joint mechanoreceptors that inform about the movement of joints and body parts in space. Kinesthesia is defined as a sensation arising from the movement of the body parts in relation to one another. These two terms are used to describe the sense of position and the movement of the parts of the body. This excludes the sense of position and orientation of the body obtained by the stimulation of visual and vestibular receptors. Receptors are the slow adapting spray endings in the joints and muscles that resemble Golgi tendon organs. The Pacinian corpuscles in synovia and the ligaments are also included in the proprioceptors. The touch receptors in the skin overlying the joint may also be the part of receptors. The pathway for this is, as you know, the proprioception is a sensation of the movements of body parts due to the joint movements, and they are transmitted in the dorsal column of the spinal cord. From medulla, that is from the nucleus gracilis and cuneatus, a significant proprioceptive projection goes to the cerebellum. Therefore, diseases affecting the dorsal column produce ataxia as they interrupt fibers to the cerebellum. Vibration sense. Application of mechanical stimuli oscillating rapidly from 2 to 400 Hz elicits the sensation, which is described as a trembling or vibrating. The ability to feel mechanical vibration is also called as palæsthesia. The sensation elicited in the lower range of this frequency is flutter, and at higher frequency range is called as sense of vibration. The sense of vibration is appreciated when vibrating tuning fork is applied to the skin, especially on the bony prominences. Vibratory sense is a composite sensation comprising of touch and rapid alteration of deep pressure sense. The receptor for vibration are the touch receptors that are rapidly adapting, especially the Pacinian corpuscles. The pathway is it is carried by the dorsal column. Coming to the clinical importance, vibratory sensibility and proprioceptions are closely related. The diseases that decrease the proprioception also decrease vibratory sensibility and vice versa. In cortical lesions, proprioception and sense of vibration are affected early and impaired severely. Depression of the threshold of vibratory sensibility is an early symptom of degeneration of the spinal cord involving dorsal column. Such degenerations are seen in chronic diabetes mellitus, vitamin deficiencies, especially vitamin B12 deficiency, and in the early part of the tapes dorsalis. Coming to the 2-point discrimination is nothing but the minimal distance that permits two touch stimulus to be perceived as two separate points when applied simultaneously on the skin is called as 2-point discrimination. 2-point discrimination threshold is a measure of tactile acuity. Receptor for 2-point discrimination are the fine touch receptors. However, identifying 2 points depends on the intactness of the cortex. The magnitude of 2-point threshold is different in different body parts. The body parts with abundant touch receptors have the smallest magnitude. For example, on the back, the 2 points must be separated 65 millimeters or more to be distinguished as the separate points, whereas on the fingertips, this distance is reduced to as low as 3 millimeters. This also depends on the degree of presentation of the body parts in the sensory cortex. Pathway for 2-point discrimination is the dorsal column pathway. So this sensation is abolished when cortex is damaged. 2-point discrimination, tactile localization, and stereognosis are severely impaired in cortical lesions as they are integrated in the cortex. Therefore, they are called as cortical sensations. Stereognosis is the ability to identify known objects by handling them with eyes closed and is called as stereognosis. The receptors are touch and pressure receptors. The pathway, it is transmitted by the dorsal column pathway to the brain. Inability to identify the object by touch is called as astereognosis or tactile agnosia. Inability to identify an object by sight is called as visual agnosia. Inability to identify sounds or words is called as auditory agnosia, and inability to identify the position of limb is called as positional agnosia. Stereognosis is one of the important cortical sensation. Therefore, impaired stereognosis is an early sign of cortical pathology, which may occur with intact touch and pressure sensation. This is also compromised in diseases that affect the dorsal column of the spinal cord. Some of the abnormalities of dorsal column sensation. Abnormalities of tactile sensation. Anesthesia. Anesthesia means complete loss of all forms of sensation. Hyposthesia refers to the partial loss of sensation. Loss of particular sensation is depicted specifically with the prefix. For example, thermosthesia indicates loss of temperature sensation, or palæsthesia means loss of vibratory sense. Causes for these conditions. Hyposthesia is usually seen in central lesions like lesions at the thalamus, internal capsule, and cortex. It affects the distal parts of the limbs more than the peripheral parts. Whereas complete anesthesia, usually it occurs in the peripheral nerve lesions. The commonest cause is leprosy. The lesion of the peripheral nerve results in anesthesia corresponding to the distribution of the sensory fibers. Complete anesthesia also occurs in complete transaction of the spinal cord where anesthesia is seen in the limbs and trunk below the level of lesion. Dissociated anesthesia, when sensation of pain and temperature is lost with the preservation of the touch, this particular condition is called as dissociated anesthesia. Some of the causes for dissociated anesthesia are syringomyelia, intramedullary tumors, brainstem lesions like syringobulbia, thrombosis of the posterior inferior cerebellar artery. The dissociated anesthesia occurs in diseases when spinal cord gray matter surrounding central canal is damaged. The fibers of the dorsal column pathway are spared in the disease process as they are placed in the periphery of the spinal cord. Therefore, tactile sensibility is preserved. The fibers of spinothalamic tract that carry the sensation of pain and temperature while crossing over to the opposite side in the spinal cord are placed close to the central canal. These fibers are damaged in the disease process that results in loss of pain and temperature. Hemianesthesia is loss of sensation that affect the face, arm, trunk, and leg of one side of the body. The causes are usually the lesions in the thalamus, internal capsule, or cortex of the contralateral side. Hyperesthesia refers to respond when the response to the sensory stimulation is exaggerated. The condition is called as hyperesthesia. The increased sensitivity to various stimuli indicates heightened activity of sensory apparatus like increased receptor sensitivity. It is seen in thalamic lesions. Hyperpathia is exaggerated perception of sensation, and it is interchangeably used for the hyperesthesia. Alloesthesia is when tactile or painful stimulus is delivered on the side of the hematosensory sensation is experienced on the corresponding area of the opposite side, and this is called as alloesthesia or alloesthesia. The causes for alloesthesia are the lesion in the right side putamen, usually that occurs due to the putamen hemorrhage. Anterolateral lesion in the cervical spinal cord, this may be due to the due to the existence of few uncrossed spinothalamic fibers. Paresthesia is it is a condition when sensations are abnormal and distressing. That is, touch may produce an unpleasant sensation almost amounting to pain. So this condition is called as paresthesia or dysesthesia. This may occur in the form of pricking, numbness, or band-like sensation around the trunk. Commonly, it is caused by the nerve compression. So this is the commonest cause of the paresthesia, nerve compression. It occurs when peripheral nerves are stretched or subjected to pressure. The commonest example is the experience of paresthesia, that is numbness and pricking, when sitting posture is maintained for longer time and when legs are crossed. Paresthesia is also caused by spinal tumors, subacute combined degeneration of the spinal cord, disseminated sclerosis, and thalamic lesions. Agraphesthesia is loss of graphesthesia, that is the loss of sense of cutaneous localization and figure writing, the sense of writing figures on the body. Graphesthesia is the function of posterior column. It is commonly caused by the lesion in the sensory cortex. Astereognosis is inability to identify a known object by palpation with a closed eye, even though the primary tactile sensibility is intact. It is caused by the cortical disease. However, it should be differentiated from stereoanesthesia, in which lesions of the spinal cord or brainstem interrupt the proprioceptive tactile sensation. Abnormalities of the proprioceptive sensation. The proprioceptive sensation means the sensation of joint movement or the sense of position of different parts of the body in space. The sense of vibration is closely linked to proprioceptive sensation. The loss of proprioceptive sensation can occur without loss of other sensation. It occurs in the lesions of posterior column. It is typically seen in tapes dorsalis, subacute combined degeneration of the spinal cord, uh, and proprioception and vibration sense are severely affected in the lesions of sensory cortex. Romberg sign is inability to maintain a balanced standing position with feet together and eyes closed is called as Romberg sign. This displays the lack of sense of position in both legs. The patient should be tested in bare feet. This is called as sensory ataxia. However, the ataxia also occurs in cerebellar disease and vestibulopathy and should be differentiated from posterior column lesion. So this is in brief about some of the ascending tracts. Thank you.